All right, thank you to the scientific committee for the opportunity to present this work. Several of the co-authors on the study do have stock options and consult with Premia Spine. Degenerative spondylolisthesis is a problem with which we're all very familiar. The gold standard treatment has been decompression with fusion historically. However, we all know that fusion or decompression alone for that matter is associated with high reoperation rates, and so lumbar facet arthroplasty is a proposed alternative method of dynamic stabilization. The only FDA-approved lumbar facet arthroplasty device on the market right now is the TOPS device, which was recently approved by the FDA. Last year in this forum, we shared the 2-year analysis that demonstrated superiority of TOPS compared to TLIF in the primary outcome measure, which we'll review. But the question that still persists and will continue to persist is, are the improved outcomes that we're seeing with lumbar facet arthroplasty durable over time? The aim of this study was to report the 3-year outcomes of the TOPS IDE trial comparing facet arthroplasty with fusion, and we hypothesized that lumbar facet arthroplasty would continue to be associated with higher rates of achieving composite clinical success, improved PROMs, and complication rates comparable to fusion. Just to review the methods of this study, this was a multi-center prospective RCT involving 37 centers. It included patients with grade 1 degenerative spondy with stenosis and neurogenic claudication. Patients were randomized 2-to-1 to either decompression and lumbar facet arthroplasty or to decompression and fusion with a TLIF, and the primary outcome was a composite clinical success score. The data was all managed by an independent third party with oversight from the FDA. This is the primary outcome score, the composite clinical success score, and all 5 of these components had to be met in order for a patient to be perceived as a clinical success. They had to have the absence of reoperation or lumbar injection, absence of a device event, reduction in ODI of greater than or equal to 15 points, absence of a new or progressive neurologic deficit, and then absence of a fusion failure, which was a pseudarthrosis in the fusion group or a spontaneous fusion in the arthroplasty group. Patients were assessed for this primary endpoint at 24 months or earlier if they were deemed a failure earlier to that for something like a reoperation or injection, and we also evaluated predetermined secondary outcomes that we'll review. The study was concluded when 206 patients had been randomized to the arthroplasty group and 93 patients had been randomized into the fusion group. At this point, and we just reanalyzed the data about 1 month ago, 140 arthroplasty patients and 67 fusion patients have been assessed for the primary outcome. There have only been 4 patients in each group lost to follow-up, and the remaining patients just have not yet achieved sufficient follow-up time to be considered for the primary outcome. In terms of the primary outcome, composite clinical success was significantly different between the groups. The arthroplasty group achieved clinical success 80% of the time compared to 51% in the fusion group. And you can see in this analysis, we went ahead and excluded fusion failure. This was significantly different between the cohorts, but I think we all recognize that there are many clinically insignificant pseudarthroses or stable fibrous unions, and so we excluded that and even still found a significant difference in this outcome. The between-group difference was such that we were able to reject the null hypothesis of equality and state that arthroplasty was superior at this time point. In terms of patient-reported outcome measures, there were no difference in any preoperative measures, but over time we see that ODI, ZCQ scores, and VAS back and leg were significantly different between the cohorts, including at 3 years. The arthroplasty devices all remained mobile at 36 months postoperatively, except for 1. In terms of reoperations, the overall reoperation rate was not different between the cohorts, 6% in the arthroplasty group and 8% in the fusion group. In terms of the reoperations that we're most concerned about, 5 of the reoperations in the arthroplasty group were a conversion to a fusion, 1 for persistent low back pain, 2 for loose pedicle screws, and 2 for persistent CSF leaks. And 6 patients in the fusion cohort required an extension of their fusion within this time period for adjacent segment disease. The arthroplasty group in this study outperformed the fusion group in the primary outcome measure of composite clinical success. The arthroplasty group also maintained motion at the index level and was not associated with increased rates of complications or reoperation. The arthroplasty group also demonstrated superior patient-reported outcome measures that were maintained at 3 years postoperatively. There are obvious limitations to this study. Patients are not blinded to their treatment group, which may impact their patient-reported outcome measures. And also 3 years does remain a relatively short follow-up for a device such as this. But we can conclude from the study that lumbar facet arthroplasty was superior to fusion in the treatment of grade 1 degenerative spondylolisthesis with stenosis at 3 years postoperatively, and we will continue to evaluate whether these results will be durable, and over the long term, does lumbar facet arthroplasty reduce the risk of adjacent segment disease? Thank you.